Hi, my name is Lindsey Roeker, and I am a Senior Associate Consultant at Mayo Clinic in Rochester, Minnesota. And it is an absolute pleasure to be here with you today to talk about some of the updates we saw at ASH, the American Society of Hematology meeting in December of 2024. And this was an exciting year for CLL, so we're going to go through some of the new data we have, some of which I think actually is very practice-changing, and we'll go through some of the details of these studies. So to start, we're going to look at some data that builds on current standard of care regimens, so things that are approved, used in new ways. And the first study that we're going to look at is the use of acalabrutinib treatment in very old or frail patients with CLL. And this was a phase 2 CLL frail trial that included patients who were either over 80 or frail, and that was defined as a frail score of 3 or higher. And patients received continuous acalabrutinib either in the front or second line setting. This included 53 patients. 46 of these patients received at least 3 cycles of therapy and are called the full analysis set in this data. And the median age at diagnosis was 81. The frail score was over 3 in about half of these patients, and just over 2/3 of the patients were previously untreated. A third were receiving acalabrutinib in the second line setting. And the median follow-up was 17, almost 18 months here. The overall response rate was 93.5%, and that 12-month estimated overall survival was 96% in the full analysis set. So these were the patients that were able to receive at least 3 cycles, and 91% in the intention to treat population. So we did have some patients who dropped out early, didn't receive that full 3 cycles of therapy. In the middle of this slide, you can see the progression-free or the overall survival curve. These data are important because we had seen some early deaths with ibrutinib therapy in particularly old patients, and this is showing that kind of that first, especially in that first period, this does appear to be a safe approach. And then on the right-hand side, you can see the changes in frailty over time. So the blue color is the least frail, the red color is the most frail. And if you take a look here, many patients had reduction in their frailty scores over time. So 53% of patients in this full analysis set actually had an improvement in their frailty score. 21% were considered frail at month 6 compared to 47% at screening. And this was all based on self-assessment. The discontinuation rate in this population of older adults was 35%. 10 of the patients discontinued for adverse events, and there were 5 deaths in the group, including 3 from infectious causes, 1 from a concomitant disease, I believe this was Parkinson's, and 1 episode of sudden cardiac death. 3 patients withdrew consent. So this is showing us that the drugs that we use, a drug that we use very commonly in either the first or second line setting, is safe, including in very old, very frail patients. The next study is one that we had done, and it's looking at an MRD-adapted duration of frontline ven-obin. So ven-obin, as approved, is a 1-year fixed duration therapy, and we know that patients who achieve undetectable MRD have an improved progression-free survival when compared to those who have residual disease at the end of therapy. So this was basically looking at, for the patients who achieve quick response, can we shorten therapy? And for the patients who do not achieve a quick response, does continuing venetoclax beyond that year help with outcomes? So patients received venetoclax and obinutuzumab per the CLL14 schedule at the beginning. At cycle 7, they had a peripheral blood assessment of minimal residual disease. If they achieved UMRD at a 10 to the minus 6 sensitivity, they were tested again at cycle 9. And if they had persistent UMRD at that point, they stopped after 9 cycles of therapy. So getting 3 less months of venetoclax exposure. Patients who were still MRD detectable at month 7, or cycle 7, then received 12 cycles of therapy, and at cycle 12 had MRD testing. If they were UMRD at a 10 to the minus 5 sensitivity at that point, they discontinued therapy. And for those who still had detectable MRD, they went on to receive that second year of therapy. And this is a look at outcomes for this approach. On the top left, you can see progression-free survival from the end of therapy. So this is comparing those who got that shortened duration of venetoclax, a total of 9 cycles, and those patients are in purple, versus those who were detectable at cycle 7 and went on to receive 12 cycles of therapy, achieved undetectable MRD at 10 to the minus 5 after 12 cycles, and discontinued therapy. You can see that both of these groups have excellent outcomes. So 12-month progression-free survival was 91% for those who discontinued after 9 cycles versus 94% for those who discontinued after 12. These were not significantly different. On the right-hand side, you can see the MRD kinetics on therapy following discontinuation. So you can see that over time, we do have loss of undetectable MRD status. On the left-hand side are those who achieved kind of that early deep response, so 10 to the minus 6 sensitivity, undetectable MRD, and kind of what's happening over time. You can see that at 12 cycles, about half of the patients still remained UMRD at that sensitivity. And then on the right-hand side, you can see those who achieved undetectable MRD at the 10 to the minus 5 cutoff after 12 cycles of therapy, and kind of their MRD kinetics when they're off of treatment. And then on the left, we actually had 3 patients who were detectable at the end of cycle 12 and went on to receive a second year of venetoclax. So that's basically cycles 12 through 24 on this graph. And you can see that for some of these patients, we actually have rising MRD during that time point. So one patient in that second year did achieve undetectable MRD at 10 to the minus 5, whereas 2 remained detectable with that threshold. Now we're going to go on to a set of data, a set of studies that are looking at BTK and BCL2 combinations. So this is where a lot of the exciting data were this year. And the first study that we're going to look at is a response-adapted approach to doublet therapy. So this is building on the idea that I plus V, based on GLOW data, an effective time-limited regimen. Also, we know that with time-limited regimens, there can be differences in outcomes for patients who do versus do not achieve undetectable MRD. And for those who are still MRD positive, can we then intensify and improve outcomes? So the major question here is, if we treat people with I plus V for a standard 16 cycles, and then we take the people who are MRD positive, can we add ibrutinib with obinutuzumab to improve the complete response rate and undetectable MRD rate for those patients who were not able to achieve that with I plus V alone? The idea here being, let's find the patients who really need that intensification rather than using a triplet, which is very effective, but also a bit more toxic. So this study included 84 patients who completed I plus V, 12 discontinued I plus V, and you can see the reasons for discontinuation on that right-hand side of your screen. 21% achieved a complete response with undetectable MRD at the completion of I plus V. So these 21% of patients then stopped therapy altogether. The remainder per protocol then went on to intensification with ibrutinib and obinutuzumab. And with this approach, the 24-month progression-free survival is 94% with a 98% overall survival rate. Of the 55 patients who received this ibrutinib plus obinutuzumab intensification, the median age was 68. About a little over a third were mutated, 55% were unmutated, and 11% had TP53 aberrancy. And the 24-month post-intensification PFS and OS rates were 92 and 94%. On the left-hand side, you can take a look at the efficacy of the patients who achieved undetectable MRD and CR after I plus V. So this is a look at their MRD kinetics, seeing that we are seeing a small number of relapses, of MRD relapses. For the patients who were not undetectable MRD or CR after the completion of their I plus V, and then had that intensification, 60% of those patients were able to achieve undetectable MRD and a CR rate, CR at 9 months after the completion of I plus V. So with that additional 6 months of therapy, we're converting MRD status for about 60%. On the right-hand side, you can see the progression-free survival from the time of completing I plus V. So this is observation of the patients who were undetectable MRD after that first I plus V regimen versus the intensification shows us the 6 months of therapy followed by observation. And you can see that the PFS curve is just a bit below the observation curve. The next study we're going to look at is the update from GLOW. So this is a 67-month follow-up, and there were a couple of things that came out of this study. So just as a refresher, this was a phase 3 study that looked at older patients with comorbidities who were previously untreated, and they were randomized to either receive an ibrutinib lead-in followed by I plus V versus chlorambucil and obinutuzumab. And this is now the 67-month follow-up. So we knew already that there was a progression-free survival benefit for IV versus chlorambucil and obinutuzumab, though now we can see that with further follow-up on the bottom left. On the bottom left, that B PFS curve, we can see the effect of IGHV mutational status. So you can see that mutated IGHV in the darker red color, that portends a longer progression-free survival when compared to those with unmutated IGHV, which are kind of that lighter salmon color. And then on the right-hand side, we see the treatment-free survival for all patients is improved for ibrutinib plus venetoclax versus chlorambucil plus obinutuzumab, so red versus blue in that treatment-free survival curve on the top. And then a new analysis that was reported here was called grade 3 or 4 treatment emergent adverse event free progression-free survival. So the idea here was, are people basically living with less toxicity with this therapeutic approach, less toxicity plus less progression? And here we can see that patients basically spend more time having treatment emergent adverse event free survival, that metric is better for patients treated with I plus V versus chlorambucil and obinutuzumab. And next up is the AMPLIFY trial. This is probably some of the most practice-changing data that came out of ASH this year. And this is a phase 3 randomized study that randomized patients requiring frontline therapy who did not have TP53 aberrancy, so no deletion of 17p, no TP53 mutations. And patients went on to receive either doublet of A plus V, triplet of AVO, or chemoimmunotherapy with FCR/BR. Here you can see the AV and the obinutuzumab schedule. So patients receive fixed duration therapy for a total of 14 cycles. There was a 2-cycle lead-in with acalabrutinib followed by venetoclax, and if obinutuzumab was used, it was given for cycles 2 through 7. So you have that acalabrutinib debulking up front. On the left-hand side, you can see the baseline characteristics. So the AV cohort included 291 patients, AVO 286, and then chemoimmunotherapy was 290. Median age across the cohorts was 61. A little under half had advanced RI stage 3 or 4. Unmutated IGHV was a little bit more than half, so somewhere between 57 and 59% for all cohorts. And complex karyotype was present in 14 to 16% of the population. On the right-hand side, you can see progression-free survival for the entire group. So you can see that the 36-month PFS for AVO is 83% versus 76% for AV, and this was better than chemoimmunotherapy, which was 67%. Now, interestingly, if you look at the overall survival, whereas the progression-free survival is better with AVO, the overall survival is actually better with AV than with AVO. So the 36-month overall survival rate is 94% for the doublet versus 88% for the triplet. And on the right-hand side is a look at overall survival with COVID-19 deaths censored. And this was a pre-planned analysis, but showing that there is a significant impact of these infectious deaths, with more of those happening in the AVO arm. Here's a look at progression-free survival parsed out by mutational status. So IGHV unmutated patients seems to be where that benefit of AVO over AV does exist. In the mutated IGHV subgroup, the progression-free survival for AV and AVO is basically superimposed. And looking at the safety summary, the serious AEs were experienced by about a quarter of patients with AV and 38% of those with AVO. Serious AEs leading to death were more common in the AVO arm than AV. And if you look at the infection rates for grade 3 or higher, it was 24% for AVO versus 12% for AV. So the differences here between AV and AVO seem to be infection-related toxicity. Next up, so as we just went through, that AMPLIFY study did not include patients with TP53 aberrancy, but we're still trying to find the best approach and whether it's feasible to use fixed duration therapy for patients with TP53 aberrancy. So this was a study by Matt Davids that looks at triplet in TP53 aberrant disease. And it started as kind of an all-comer study and then was enriched for high-risk disease. So of the 72 patients treated total, 63% have a TP53 aberration. And if you look down in the IGHV mutational status, a majority have unmutated IGHV. There's also a fair number of Notch1 mutations in this cohort. So patients received AVO for a total for about a year. For those who achieved undetectable MRD, they could discontinue therapy. If they were positive, they received another 9 cycles of therapy. And then if they still remained positive at that end of 25 cycles, so about 2 years, they actually could continue on therapy. Here is a look on the left-hand side at response rate. So this is while on therapy, you can see the deepening of responses in both the TP53 aberrant population as well as the overall population. And then on the bottom of those bar charts are the MRD rates in bone marrow for those with TP53 aberration on the left and the overall population on the right. So of those who had a TP53 aberration, 42% achieved a CR and undetectable MRD at cycle 16. So, an approach that seems to make sense in this population with achievement of undetectable MRD, including these really high-risk patients. On the right-hand side, you can see the survival curves. So we see the overall progression-free survival as well as the overall survival, and then it's broken down by TP53 aberration. So you can see that there is some detriment in progression-free survival with the TP53 aberrant patients. Though as a fixed duration therapy, it does seem to be pretty effective. Next up is a doublet combination. So this is sonrotoclax, a different BCL2 inhibitor with zanubrutinib, and this is a frontline study. This is a little bit different in that in this study, these drugs are used in combination as a continuous therapy. So this is not a time-limited approach. And there were 2 different doses of sonrotoclax tested along with zanubrutinib. There were 51 patients treated with the lower dose of Zanu versus 86 with the higher dose of Zanu. You can see that 22% had TP53 mutation, 9% had deletion of 17p, and unmutated IGHV was there in about 60%. Here's the look at progression-free survival on the left. So with a median follow-up of about 20 months, no progressions were observed on sonrotoclax 320 with zanubrutinib. Now, again, this is a continuous therapy, so these patients are receiving therapy this whole time. And on the right-hand side, in terms of overall response rate, it was very, very high for both arms, obviously. Here's a look at UMRD rates, and you can see that by week 24, with the 320 milligrams sonrotoclax dosing, 78% had achieved UMRD4. By week 48, 91% were undetectable. So very deep responses here. Now, switching gears a little bit, the next study that we're going to look at is CLL-321, and this was a randomized phase 3 study of pirtobrutinib versus investigator's choice, and that was either Idela-R or bendamustine and rituximab. This was in patients who had previously received a covalent BTK inhibitor and were requiring therapy in the relapsed refractory setting. Patients were randomized 1-to-1. The median age of this cohort was 66 to 68. And if you look at the red boxes in the patient characteristic table, we can see that a lot of these patients had high risk features. So TP53 aberrations were present in about half, just over half, 54%. Between 80 and 93% had unmutated IGHV, and complex karyotype was observed in 72% of those treated with pirto versus 59% of those treated with investigator's choice. 15% of the cohort had received more than one prior covalent BTK inhibitor, and BCL2 inhibitor exposure was present in about half of the patients. So we had about half of these patients who were double exposed versus half that were just exposed to covalent BTK inhibitor. And here you can see progression-free survival. So on the left is the IRC assessed progression-free survival. And you can see that the progression-free survival, pirtobrutinib reduced risk of PFS or death by 46%. There were no significant differences observed in overall survival between the arms, but this is probably because there was a very high crossover rate. So of those who progressed on investigator's choice, 76% of those patients went on to receive pirtobrutinib. The safety profile reported here is very similar to what was seen in the phase 1/2 study of pirtobrutinib. That was the BRUIN study. So overall, very well tolerated. Interestingly, there's actually quite a big discrepancy in this study between progression-free survival and time to next treatment, suggesting that a lot of these progression events were actually just detected by scans and that patients hadn't really clinically had any worsening disease that required a next therapy. So pirto reduced the risk of starting a next treatment or death by 63% with a median time to the next treatment of 24 months. And then this was a study, an updated look at the PVO data. So this is frontline, and patients received triplet combination with pirtobrutinib, venetoclax, and obinutuzumab. They started by getting pirto and obin. The venetoclax was added in cycle 3. They got a total of 6 cycles of obin, and then the therapy continued through cycle 13. And here you can see that the median age of the cohort was 63. You can see kind of the risk features here. So 79% unmutated. There were a fair number of TP53 aberrations. 9% had del17p, 10% had TP53. So overall, 13% had TP53 aberrant disease. In this study, 3 patients discontinued prior to cycle 3, 66% completed cycle 7, and 41% completed cycle 13. So 36% of patients are off of all therapy. 5 are continuing with an additional 12 cycles of therapy because of their MRD status. And here we can see MRD at serial time points. So you have the end of cycle 7 in both peripheral blood and bone marrow. So 93% achieved UMRD at a 10 to the minus 4 sensitivity in peripheral blood versus 91% in bone marrow. At the end of cycle 13, UMRD 100% in peripheral blood. So incredibly high MRD rates. And there were no observed progression-free progression events or deaths with a median follow-up of almost 12 months here. In terms of safety, we can see that dose reductions were required in pirtobrutinib for 21% and venetoclax for 31%. So switching gears a little bit, here we see the results from Transcend 004, and this is a study of lisocabtagene that was combined with ibrutinib. So we had already seen the results of the lisocabtagene alone cohort, but now this is looking at the idea of adding ibrutinib into the treatment with the idea that ibrutinib not only helps with disease control, but also helps with T cell fitness and might enhance response rates and things like that with CAR T in CLL. So patients were screened, underwent lysocell manufacturing, then received lymphodepletion, and lysocell all of this time. So through the lysocell manufacturing, lymphodepletion, and with administration of the cells, patients were receiving ibrutinib. There was a dose escalation and a dose expansion phase of this study. And on the right-hand side, you can see the patient flow. So 65 patients were in the intention to treat set. There were a number of patients who did not receive the therapy as described, so 9 total patients, some because they no longer met eligibility criteria. 2 patients died, 1 withdrew consent. There was 1 patient who received a non-conforming product, and then there was one event where a patient discontinued ibrutinib for toxicity before they could get the lysocell infusion. So a total of 56 patients received ibrutinib plus CAR T. The efficacy set is 51 patients, and 17 patients still have ongoing follow-up. On the right-hand side, you can see these baseline patient characteristics. So 55% had double refractory disease in this population of patients who received lisocabtagene plus ibrutinib. And here we can see that the median follow-up time is just over 2 years. The median time to response was about a month, and the median time to CR was 3 months. The median duration of response was 41 months, and overall this response rate is 86% with a CR/CRI rate of 45%. So excellent outcomes for a CAR T study relative to the patients who had received just CAR T without ibrutinib. You can see the progression-free survival by best overall response. So those patients who achieve CR really do have excellent outcomes with this combination approach. So really exciting data here. And then this is a look at epcoritamab, a bispecific T-cell engager, and specifically this is being used in patients with relapsed refractory CLL. This was an update of the EPCOR CLL-1 study. And the study design is described on the top left. There was the original expansion cohort of 23 patients where there was kind of 2 step-up doses and then a full dose by cycle 1, day 15. There was a cycle 1 optimization cohort that included 17 patients that added in an additional dose to try to mitigate some of the risk of CRS. And you can see that the cohorts were similar. The first expansion cohort with the cycle 1 optimization cohort, the baseline characteristics are overall very similar. The median number of prior lines of therapy was 4. And all patients had been previously exposed to a BTK inhibitor. 85-ish% overall had been exposed to a BCL2 inhibitor. And on the right-hand side, you can see that the addition of that additional step-up dose to decrease the risk of CRS. So on the right-hand side, 82% still experienced CRS, but all of the cases were lower grade, whereas there had been some higher grade CRS with just that original expansion approach. And the take-home message here is that optimization, so that third step-up dose, can mitigate CRS, ICANS, TLS risk. Here is a look at progression-free and overall survival. So at a year, the progression-free survival estimate is 52%. Overall survival estimate is 70%. There's limited follow-up, but this optimization approach where you're adding in that third step-up dose doesn't appear to affect efficacy at all, with an overall response rate of 61% and a CR rate of 39%. And then finally, we'll take a look at the BTK degraders. So this is a class of drugs that are exciting as we're using covalent, non-covalent BTK inhibitors in the clinic and having patients who still experience progression. There were updates provided on 2 different drugs. So the first is NX-5948. The second is BGB-16673. Both of these studies contain 60 patients. Median prior lines of therapy for both studies is 4. These are highly relapsed refractory patients with really difficult to control disease. And with these swimmers plots, you can see that there are patients achieving durable disease responses with both of these drugs. You can see the waterfall plot on the left with an overall response rate for NX-5948 of 76%. The overall response rate with BGB 16673 is 78%, and you can see the PFS curve on the bottom right. So an exciting class of drugs that I think are going to be useful for our patients with relapse refractory disease in the future, and I think this is a class of drugs to keep our eyes on. So with that, I just want to thank you for your time and attention and for allowing me the opportunity to present these exciting data.